Good afternoon, everybody. Welcome to the Born Ontario briefing. For today, we are going to concentrate on the use of data and the data that Born Ontario has in the system and what we're doing with it. In the past, most of the calls have been associated with what's going on with the build, and now we're trying to branch out a little bit while still giving information on the build, but also giving information on what Born Ontario is up to in relationship to the activities we have going on. And so one of the big activities we have has to do with the science and the data. My name is Anne Sprague. I'm the Scientific Director for Born Ontario, and I'll be doing the presentation today. Also online is Shane Fell, who's the Born Ontario epidemiologist. And at the end, when we have question periods, you can certainly direct questions to either one of us. And I want to just let you know that there are two ways to be able to ask questions at the end. Right now, all your lines are muted. But at the end, there is a small screen on your computer that allows you to ask questions by going into the chat area, and we will be able to pull up those questions. Or you can also unmute your phone by pressing, to ask a question, you press 01. And if you want to remove yourself from the queue, you press 02. So if somebody in front of you has asked your question and you decide you don't need to ask that question anymore, you just press 02. But we'll go over that again at the end, closer to the time when we're actually going to be asking questions. So we'll go ahead with the presentation. And most of you are probably signed in to the web and can see the slides on your screen. And if you're not, the address for the web was provided in the email that was sent out. And you may also be just on the phone, and you can hear what we're saying as well. So the objectives today are to actually review Born purposes and what we're doing, what the purposes of collecting the data are. And then really what I've termed the 5 W's, of Born data. Finding out, giving you an idea of who's using Born data, what they're using it for, where they can access Born data and where you can access Born data, when it's appropriate to use aggregate versus record-level data, and why Born data is undergoing changes within the new build and what we're doing in relationship to that. So to start us off about this, I thought it was really important for you to understand a little bit about the Born purpose and what it is that we have submitted to the Privacy Commissioner about the data that we're collecting and what it is that data is going to be used for. And so this is a bit wordy slide, but you can see here, especially looking at the areas that are italicized, the primary purpose for Born is to identify individuals or settings where appropriate care has not been received and facilitate access to care and treatment for mothers, infants, and children. And so, we're really about trying to find out who, in fact, did not get appropriate care. And that appropriate care might have been that a baby was missed, for example, and didn't get newborn screening. And some of you may have seen the example before of perhaps a baby that was born in one institution and then because of gestational age issues or complication issues is transferred to another institution. And both may have thought that the newborn screening was performed, but in fact nobody did it. And so when that data comes into Born, we're able to identify these individuals or settings where care hasn't been received. And that's just one example. There's other types of clinical examples that we could give as well. Secondly is to facilitate continuous improvement of healthcare delivery tools to minimize adverse outcomes. So, for example, if there was better ways to do screening, better cutoffs for screening. By collecting all the data that we have in Born, we're going to be able to look at the sensitivity and specificity, positive predictive values, those sorts of things of data, and be able to make recommendations and develop tools to minimize outcomes associated with that. We're also going to be able to determine where maternal or newborn outcomes are clinically or statistically discrepant with accepted norms, and maybe raise alerts where necessary. And that doesn't mean at the level of the individual. That means perhaps at the level of an institution or a LIN or something like that, where we see that perhaps there's something that looks really out of place compared to everybody else. And many times that may simply be a mistake in the way that the data was entered or coded. But in order to determine that, we take a look at all that data and we find out when those changes are, or when those alerts are there, and we get back to people about those sorts of things. Fourth, we want to enable healthcare providers to improve care by providing information and tools to compare their outcomes and performance with peers. And certainly with the new legislation in the province of Ontario on quality, the Excellent Care for All Act, we certainly want institutions to be involved in looking at their outcomes and looking at the quality of their care, and certainly providing peers or looking at peers and benchmarks. And that's part of the process as well that the Born Ontario group is developing in terms of a dashboard, a clinical dashboard for the province. Fifth, we want to identify areas where best practice evidence needs implementation, and that's knowledge translation strategy. So if we know that a best practice guideline, a well-evidenced best practice guideline has been put out, we may work with groups to be able to evaluate their data and find out if that best practice guideline has been implemented in their area, and then also to figure out ways to help them with implementation if there's a problem with the outcomes. And finally, Born's purpose is to create reports that can be used to provide Ministry of Health and Long-Term Care, local health integration networks, public health units, etc., with comprehensive and timely information about mothers, babies, and children in Ontario. So that's really the overview of the purposes of what Born is set out to do, and now how we use this data for those to make those purposes live is what we'll see a little bit more of. Of course, the secondary use of having data is the ability to do some research. So generating those really important questions where we want to gain knowledge, learn a little bit more. And so because we do have data that's collected within the registry, it can be used for research. And the guiding principles for that is that the research plan is submitted and Born actually has the data to inform that study, that there is Research Ethics Board approval, and the researcher can meet requirements for the security of the data. We have pretty rigorous policies and procedures in place in terms of protecting our data and protecting the security of the individuals that are in that database. And so we certainly have rules around that. And as long as the research question's valid and we have the data and there's REB approval and we can de-identify the data set and the researcher can meet the requirements, then we're happy to facilitate that, both for, maybe simple research questions and something that could be more innovative so that we learn a little bit more about our population. I think most of you know this. You've probably seen this slide a lot, but it is to remind you that Born is a PHIPA registry and that we were granted status as OPSS originally, and the name was formally changed this month in the legislation. So we are now in the legislation as Born. And that status affords Born the ability to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving, again, those words you'll see over and over again related to Born, because that's really our purpose in existing, is to facilitate or improve provision of health care. And as we've mentioned, there's pretty rigorous policies that go along with that. So this is the Born privacy structure, just so you understand a little bit more about it. But you can see Born sits within the CHIO organization, and so the CHIO Board of Directors and the Quality Committee of the Board of CHIO is ultimately responsible. Then down through the CHIO CEO, the leadership team here at Born. We have a Privacy and Security Review Committee, and under that sits a Data Dictionary Review Committee and a Disclosure of Personal Health Information Review Committee. And so that committee structure guides what it is we do with data in Born. So I just also wanted to just take 1 second before we get into the data just to remind you a little bit of the privacy landscape. Most of the data that we collect actually comes from hospitals, healthcare providers, so you can see physicians, nurses, and allied health. And those health information custodians are allowed to share information within the circle of care. They're also allowed to disclose that information, especially personal health information, to a registry. So Born is a registry, and that means that hospitals and doctors and labs can disclose information to Born. Other health information custodians require information for their work, but they don't have direct patient access. And you can see those are public health units, the ministry, the LINs, that sort of thing. And so Born works with those groups to be able to provide them some of that data that they don't have direct at their fingertips. There are other under the privacy legislation. There's organizations that are prescribed entities, and health information custodians, those people who have the data about the patients, are allowed to disclose personal health information to an entity for the purposes related to planning and management of healthcare. And you can see Cancer Care Ontario, the Canadian Institute for Health Information, ISIS, which is the Health Information Data Warehouse in Ontario, and the Pediatric Oncology Group are all what are described as prescribed entities and are allowed to have information. So that just tells you a little bit about the privacy landscape. So here's Born now, and Born we get data in through a number of ways. You can see in the bottom left is the person sitting within an institution who is now entering a delivery record or pregnancy information or lab results or whatever else that's going into the Born system. I couldn't find really great pictures for the other ones, but certainly we have people who actually don't enter directly but upload information into the Born system. So if there's an EMR in their setting, there's a program written and that data comes to Born. And then there's also a group of people who submit data to Born from outside labs or that sort of thing, where in fact through prenatal screening or through newborn screening or whatever, that data comes into Born. So that's just kind of a pictorial representation of what happens. So in the current state that we're currently in, Born is 5 data sets that support different clinical needs. So as we mentioned, there's newborn screening and there's prenatal screening. There's the NIDA sort of birth database. There's midwifery, and then there's what was formerly known as the Fetal Alert Network, which is the database that looks after congenital anomalies and the care of those women and children. Right now, there's no communication between those databases, and any linking that we want to do to find out what happens to people from one to the other is done mainly by probabilistic matching. So we are able to take, a mother's birth date and a baby's birth date and a postal code and all those things and throw them together and come up with a match that says this is very likely this mother that's attached to this baby. However, in the future state, and what we're building now, and actually in the building process, we're actually testing now, is one database that will allow a longitudinal view of pregnancy, birth, and the early newborn period. Down the road, as a child grows, we'll add more. So we can look at that longitudinally, or we can take specific pieces. So we can look at the birth process, or we can look at the NICU stay, or we can look at the prenatal screening testing, that sort of thing. So that's what we call an encounter. And the system is very unique in that it has the ability to automatically, through something we've built, link and match those mothers and babies together, and babies to siblings in the future, and that sort of thing. So that's sort of the future state that we're getting to. Now, probably more interest to you is the actual data that comes out of Born. And at the point of care, so those health information custodians, they can retrieve and use the data they've put into the system. So if you're in North York General Hospital, for example, and you are a healthcare provider there, and you've put data into the system, you can go in and retrieve your data out of the system. Obviously it's really important that you follow the rules of North York General in terms of privacy, and that you don't do anything with that data that jeopardizes that personal health information of that woman, but you can go in and see your own data. You can do a download of your own data, that sort of thing. You can also sometimes see aggregated data for your comparison to others, and you do have a participation agreement with Born that outlines your best practice principles for protection of that data. So that's at the point of care. And right now, the only other group really that can get into the data is us here at Born Central. And in regards to that, what we can do is we can aggregate and remove personal health information to use it or disclose it. And that could be for reporting, it could be through dashboards, it could be through guiding policy. We can only disclose personal information back to individual health information custodians for directly facilitating care to an individual, and that's the rules under which you live by. We can disclose personal health information for research, but our best practice is actually to de-identify it to the best extent possible. And there's lots of research going on with the risk of re-identification of people from data sets, and we work with Dr. Khaled El-Aman at the Health Information Laboratory at CHIO, and we work quite hard to de-identify data sets. So data can go out of BORN, but for the most part, we try and aggregate it and remove personal health information. And you can see just some examples, it may be about specific types of research or maybe aggregate, and we'll go into that now. PHIPA does allow disclosure of data not for research when, as I said, to improve and facilitate care to individuals or data sharing with entities, and there is approval process for that. So now I want to talk to you just a little bit about data from BORN. And the examples that I'm going to show you are ones that we've done over the last couple of years. It wouldn't be any fun attending a presentation about data use if you actually didn't see some data. So we're going to show you some data. And I want to first acknowledge the team of analysts that we work with. They're just a tremendous group of people. And we, sometimes ask them to do some pretty impossible things with data, and they manage to find a way to do it. So certainly, Deshane Fell, our epidemiologist, helps me with guiding the team, and that would be Hualing Cao, Monica Prince, who are our full-time data analysts with BORN, and then we have some people that we work with kind of on contract who do work for us as well, Abdul Yassin and Xiaowen Tu. And then, so those are the group, sort of the core people. We also work with Tianhua Wang from the maternal serum, the prenatal screening group. And so all these people are very, very skilled at what they do in terms of data. So I want to acknowledge them. And basically, who is using BORN data and when we get it out of the system? Hospitals and care providers. So, they're the people putting data in the system for the most part, and they're the people who are using it through the online reporting system, but then also asking us for help sometimes. There are limitations to the online reporting systems in most of these the systems, just because you have very limited ability to compare yourself to others. Or to look broadly across the province. You can kind of see yourself and your own region sometimes. So sometimes they ask us for help in terms of doing that. Certainly government and policy developers are interested in this data, and that's the Ministry of Health and Long-Term Care Strategy Division, the Maternal Child Youth Ministry Services, Health Quality Ontario, ECHO, which is the Women's Health Group, PCMCH, the Provincial Council for Maternal Child Health, Public Health Agency of Canada. So these are people that are interested in the BORN data. There are also people who have asked us for help in terms of being from professional associations and special interest groups. So the Society of Obstetricians and Gynecologists of Canada, the Canadian Perinatal Partnership Coalition, the Association of Ontario Midwives, Maternal Child Regional Programs. So these are the kind of people who are also interested in data. Health units across the province, public health units. Certainly researchers and us at BORN, what we call BORN Central, who can dig into the data and provide help for people doing that. So the next set of slides I want to show you actually are from some of the examples that I've just given you in terms of why people use the data. And so, when people come and ask us for aggregated data, it's usually because they're developing health or social policy or background for funding decisions. They're examining health service across Ontario, and they want to know what's happening. Performance measurements, so they're looking at themselves compared to others. Trending particular indicators over time. Supporting data for proposals. Doing quality improvement projects. Supporting public health programming. Generating research questions. Or producing very specific reports on different items. So this is just an example. You may not see the actual numbers. It may be too small for you. But in relationship to supporting policy decisions, one example is when the Ministry of Health and Long-Term Care and PCMCH were working together on the Retinopathy of Prematurity project. They were trying to figure out the number of infants that might, in fact, fall into these categories where they potentially could need retinopathy of prematurity screening. And remember that the group were trying to set up satellite cameras across the province where they could then do screening in the baby's own community versus keeping them in a bed in Toronto, and then, tying up beds for babies that could have this testing done. In other words, so they came to us and said, well, what are the number of infants with either a birth weight less than 1,500 grams or gestational age of less than 30 weeks, because those are the babies that most would likely be this, need this screening, and, by line of residence. So we produce a table like this, and we give it to them, and that helps them, make some decisions about where things should be located. So that's the kind of thing about policy decisions. Also, other policy decisions that were made through with PCMCH and the government had to do with level 2 beds, adding level 2 beds and ICU beds in the province. And so, we provided some data about number of babies and that sort of thing. And then also related to the implementation of fetal fibronectin in Ontario, we were just looking at number of cases of different things related to prematurity. So that's how policy decisions and why people might want born data. For health services, you can see here there's lots of data in born that would interest to health service. And this table just actually shows you birthplace for babies needing level 3 neonatal care in the GTA lens, and this was done on fiscal 2008-2009 data. Again, numbers might be too small to see, but what they're interested in is we were just looking at gestational age less than 30 weeks, gestational age less than 32 weeks, and birth weight less than 1,000 grams. So, those babies, most of those babies at less than 32 weeks should be born in a tertiary center, and this just shows us how many babies are born in level 1, level 2, level 2 plus centers. So again, this is the kind of thing that would be helpful for, making learning about health services and what's actually happening in practice that may need some correction. Other kind of health service things that we've done over the past year or so looked at the uptake of prenatal screening by LIN of maternal residents, so you want to know around the province. Rates of diabetes, for example, are important because women who develop gestational diabetes in pregnancy may then go on to develop type 2 diabetes later in life, which has health policy implications. We looked at rates of birth for women who reside who are giving birth in Ontario who reside in other provinces. So you can imagine the eastern part of Ontario is sitting on the border with Quebec. So, how many women from Quebec are giving birth in Ontario, because that has implications for resources. Those kind of things. Or women that are born, babies, that are born here have to be transferred around the province. We did some work on late preterm births. We did some work on full-term babies needing NICU care. So what's the number of those? First trimester visits. All of these are examples of health services. And this one, this is a good one. Just a particular hospital came to us and said, in our catchment area, how many women who live here actually give birth in other places? And this is the kind of data that we can look at by postal code. Then there's the whole issue of comparison with others or continuous quality improvement projects. This is elective repeat cesarean sections in low-risk women not in labor prior to 39 weeks. There are some pretty good not clinical practice guidelines, but evidence out there that says, really, if you're not in labor and you're planning a C-section, really the closer you are to 40 weeks, the better it is to get done. Now, we all know there's problems with that in relationship to capacity in the system, that, in fact, some of them get done before 39 weeks. But you can see that this was 09-10 data, and if you look at the yellow at the bottom, it looks like probably about 57% of C-sections in Ontario were done in this target group prior to 39 weeks. So there's work we have to do in the province of Ontario to correct that. And then finally, things like trending over time. This is from our latest set of reports that haven't been released yet, but this is just labor induction by fiscal year. And so you can see this is over a 5-year trend, and you can see, as we all know, that rates of inductions have been steadily kind of creeping up. So this just shows that example. And there's other things that we could trend over time, such as smoking or cesarean section. And then lastly, a lot of people come to us, they're not ready to do their research yet, but they're looking for data to support their research. And so this graph just shows us, and I didn't put names of hospitals in here, but this is, a group that was trying to figure out how much of the time, what percentage of the time was BMI entered into BORN. And so you can see in Hospital 1, in the 3 fiscal years, they didn't enter it at all. Hospital 2, low percentages. Hospital 5 at the bottom, so 55% in 2007, 74% in 2008, 67% in 2009. I can tell you that BMI is one of those data elements that is being added to the newborn build, just because it is so important from a health services point of view and from an outcomes point of view. We've learned by some research done in this region and throughout the province how important BMI is, and you all know that we have a burgeoning problem with that. So that's really some data slides just to show you how BORN data can be used. As I mentioned, we also produce reports. On the left side, the public health reports from using 2008 data were released last year. In the middle, just some reports on H1N1 that we did as we collected H1N1 data through the province. And on the right-hand side, perinatal health reports using 09-10 fiscal data that are not yet released, but this is our next release that will happen hopefully in the summer or early fall. So you can see, we're pretty busy with data and using that data to support a number of different projects. So, in terms of just giving you some ideas, in 09-10 we had over 80 requests of varying complexity for aggregate data, and I should just say that this is only based on the results from the NIDA perinatal database. As BORN really grows and develops and matures, we are going to have a lot more data requests when we start to have the ability to look at the time from prenatal screening, very, very early pregnancy, right through to newborn screening. There's going to be many, many more opportunities for data in that system. And we've had 6 requests just last year. I mean, we've had more, but researchers for record-level data. And so, there is a process whereby people can request record-level data that they then can manipulate themselves to do, answer questions, to do regression analysis, to do lots of statistical stuff. So we are expecting an increase of data requests. And so just to give you an example, I emailed our researchers that we've been working with in the last year or so and asked them, could I just, sort of give an outline of some of the projects that are being done. So from a research point of view, there's really interesting stuff being done. You can see here one researcher has been doing some GIS mapping of adverse perinatal outcomes and hotspots in the province where that occurs. Another group doing the relationship between air pollution levels and adverse perinatal outcomes. So, stuff we don't know a lot about yet, but they've had a very unique opportunity to look at our data in relationship to the air pollution stations in the province and looking at women who live within those areas. We've got people looking at maternal and neonatal outcomes associated with BMI classifications. There's secular trends in induction of labor. There's a group looking at adolescent pregnancy outcomes. We've had a group that's looking at subsequent birth outcomes for women who've had perineal trauma, 3rd and 4th degree lacerations. We've had groups looking at impact of diabetes and obesity on breastfeeding. This is just an example. There are more. One of the things I tend to do when people get to us with research requests is make sure that they know other people who are working on similar topics across the province so that we make the best use of everybody's resources. So, really good questions being asked from the research community, and certainly would encourage people to think about using BORN data. We also provide a service where we will help you in terms of providing an estimate of what it would actually cost to use BORN data for research. So the question now, the where question, where they access BORN data, people actually input data into their system, can access their own data in their site with the approval of their site lead, and they have some ability to compare among sites and levels. Some people or groups request aggregated data from across the province from BORN. Some people or groups request data from other clinical programs, so we can help people until all those data groups are in BORN. We can help facilitate data requests if you want to look at midwifery data, prenatal screening data, newborn screening data, those sorts of things. And there are data request forms both for aggregate data and for research record level data on our website. And certainly you can look there or email me, and I'd be happy to help you with those. We do have a cost recovery model for researchers. We will help them prepare estimates prepared to go in with their grant submissions so that when you're putting in a grant for funding, you can appropriately apply for appropriate resources to use data as well. And some agencies and departments, again, we will charge for data. It just depends on the extent of their data requests. I will tell you that in the newborn system that's coming in the fall, there will be a fairly robust reporting tool attached to that so that many people will be able to do much more data manipulation and pulling data from the system by themselves. So that will be an enhancement to the system. Again, people say, well, what kind of data should I request for BORN and when to use aggregate versus record level? The vast majority of people can get by with aggregate data from BORN. It depends on the question you're trying to answer. And even for people who want record level data, as I mentioned, BORN will always try and aggregate personal health information. So, for example, instead of people will say, well, I need maternal date of birth. So instead of doing that, we'll probably ask you if we can give you maternal age at time of birth, and even better yet, in intervals. If you say to us, well, I need the date of birth because I want to calculate a mean, then that's something we can provide for you as mean age, those sorts of things. So again, the least amount of personal health information that we can release, the better it is. Data from BORN, why BORN data is undergoing changes in the new build, and the team of BORN coordinators will be working with hospitals and many people around the province to update you in the coming months about any changes that are going to occur. There's not huge changes to what you've been currently collecting in NIDA or midwifery. It just may be that we've switched things around a little bit. We've changed terminology. So, for example, in the old system, it still talked about insulin-dependent and non-insulin-dependent diabetes. I mean, we're switching to use up-to-date terminology like type 1 and type 2 diabetes. Hypertension stuff has been updated. We've added BMI. So, things that needed to be done and things that you've been telling us over time need to be corrected. This was our opportunity to do that. So we did have various stakeholder input as we went through that, and people, helped us get the right data elements. A little bit better data on infertility, for example, those sorts of things. So as I mentioned, new data elements that are critical to outcomes. We did some data consolidation. So when you bring 5 data sets together and people are asking the same question using different terminology, that's a bit of a problem. So we did data consolidation. So, some people asked about estimated date of birth, others asked about estimated date of confinement, others asked about due dates. So, we made a happy medium and chose one. We deleted some data elements that had poor quality data or that were very difficult for people, and so we heard your feedback on that and have changed things related to those data elements. And then simply, we are trying to reduce keystrokes for users so that there's not unnecessary data entry. If a field could be pre-populated because a woman was seen in prenatal screening and they've already put her due date in, her estimated date of birth, EDB, then that's going to come through the system as much as possible so that you don't have to enter data if it's already been entered by one of the other clinical programs. Still to come for BORN, and you can see the future. We're currently involved in user acceptance testing, and that will go on over the summer months. And some of the hospital people will be involved more as we go forward with that. There will be much education and training on the newborn data elements and the data entry screens. We're developing a data element review or a request change cycle through the committees that work with BORN. And there will be eventually new data request forms for those of you who want data that mirror the new data dictionary. So, as the data dictionary is changed, all of the forms have to change as well. So our take-home message in my last slide today before we get to the question period, I think, when we're talking about using BORN data, all measurement and the decisions, and you can see how people are making decisions based on BORN data, hinge on timely, accurate documentation and data entry. And I know that the team here has been working with many different groups around the province, looking at business processes for getting born data in the system. We realize that it is a tremendous amount of work for care providers to get data into the system, but you can see the value of how that data is used to guide policy and to guide decisions about care and how it can be used. So, you know, it does depend for all of us on timely, accurate documentation and data entry. That you're not alone out there. Born Ontario has a group of regional coordinators and nurse coordinators who help work with you to achieve the goals of that accurate documentation and data entry. And those coordinators, if you're not sure who your coordinator are, certainly look on the Born website, but that coordinator, I can guarantee you, has been in touch with people in your institution. And I think the final take-home message is that the Born system is an excellent tool for helping hospitals, labs, programs meet the requirements under that new legislation called Excellent Care for All Act. Maternal child can be ahead of the curve in terms of promoting quality care for mothers, babies, and children in the province of Ontario. So I hope I've provided for you an overview of the Born data, how it's used, and then the 5 W's, the who, what, where, when, why. And I'd be happy to start to take questions. So again, 2 ways to ask questions. You can go on the chat line that's there on the side of your screen and enter the question there, and we'll look at it that way. Or we can also take your questions via phone. Again, if you want to get in the phone queue, you dial 01, and that will put you in the queue, and we'll answer questions. And if you want to be removed from the queue, you press 02. So, Britton, do we have anybody? No questions? Wow. Bottom of the chat box. Okay, so somebody asks, could you please clarify whether health units still have access to record-level data? Carmen, we are working right now. It's very inconsistent across the province. Some health units still have access, and some never had. So we are working with a group led by Paul Fleiser through the Toronto Public Health Unit. We're working with that group to establish the best way to provide health data to help public health units to help you with your mandatory reporting through your public health standards. Again, not a finished process yet, but we are working on that. So there's also in the chat box, do we have to pay for accessing data for public health unit planning from Niagara? Again, same answer. We haven't established anything yet. Researchers, we do ask, because of the amount of time we spend doing data de-identification and stuff, we do charge those groups for access. Right now, we haven't finished our discussions with public health and in the best way that we're going to be able to do work with public health units. So that's still to come. There is a phone call. Oh, sorry, there's still one online here. Timeline for education sessions related to Born and new data elements data collection. I would presume that's going to be done summer and early fall. So that's where we're at in relationship to that. I'm going to take a call. There's one from a 905 area code. Go ahead and ask your question.
Hello, it's Philippa Holowati from Halton Region. Oh, can you hear me?
Yes, I can, Philippa.
Oh, actually, all right. So thank you very much for the presentation. I see things have been coming along really nicely. So I have a couple of questions. One is, as an epidemiologist, I appreciate that public health, that some of the needs, particularly in relation to indicators for program standards, are in fact not related to patient care. But I think I'm uneasy to see public health units put in a box that says that we don't do patient care, because my understanding was that you were starting with the 5 main patient care sources and data sources, but that there was an acknowledgement that we have the whole healthy babies, healthy children patient care system, and that in fact public health is the next along the line in looking after these women when they immediately come out of hospital. So, I mean, families, physicians too, but it's just to clarify that there are two different needs for public health. One is around the aggregate data and some sort of questions related to the data, and the other need is for people in healthy babies, healthy children who get the information, the Parkins from the hospital, and have to key enter it all again and have their own database. That in the end, I would imagine that hopefully the vision is that it then becomes a more seamless system.
Yes. So as I mentioned, Philip, I think we all recognize that, public health is an important partner within Born. We haven't quite figured out all the details yet, but it is part of the process. And I know that Mari, the director here, has been working with the Ministry of Child and Youth Services in relation to ISCUS and thinking about other aspects as well. We recognize that we all work together to improve the care for mothers and children.
Excellent. And I mean, of course, that in itself is going through some changes now anyway. Yes. So thank you for that one.
Okay.
My other question is just, I see that you are producing the LIN reports for 2009-10, and I'm just wondering if there's any thought, will there be a public health unit one that's based on some of those, like the 2008 report?
Are you asking, or would we produce another one for 9-10?
Yes.
Okay, so we haven't quite figured out within Born yet what our strategy is going to be, and Deshane, feel free to jump in. But essentially, most places wouldn't issue reports in 1-year cycles just because of the huge amount of workload that it takes. For example, most places issue reports on 3 to 5 year cycles. We haven't quite determined where we're at yet with that, but it's certainly within our planning process.
Thank you. And in fact, it might not be a glossy thing that is required for public health. It might be sort of the number of babies born, the percent low birth weight, and a few other indicators. And particularly now with some new performance indicators, not that there were many round babies that came out of the ministry, but certainly there are some just key numbers. And I mean, certainly when I've asked for numbers of babies, I have it when it was available, and I'm very grateful for that.
Okay, thank you for your information.
Thank you. Bye-bye.
There's a call from 416.
It's Joel Ray at St. Mike's. How are you?
Hi, Joel.
I'm sorry to disappoint you by being on the line, but your talk was great. The quick question, there's two of them. For your landing point at ISIS with Born, the Institute for Clinical Evaluation Sciences, do you know when that is?
We have to get our final privacy approval from the Information and Privacy Commissioner's Office, and then we'll be ready to think further about ISIS. Okay, because, it's such a potential expansion on what you'd call kind of long-term outcomes assessment. Yeah, that's definitely on the list when everything is finally approved. And for the prenatal screening data set that's kind of housed traditionally at North York General Hospital, just remind me, what's the earliest time point in year that you're getting data for? That I don't know. So that I would have to get back to you on. No problem. And, I know I had bugged Marie once about this in a very quick manner because the meeting had ended, but really pushed to go back earlier because there's really some interesting things about utilization and even long-term post-pregnancy outcomes that can be ascertained, but, the follow-up period needs to be long enough. So we haven't figured out exactly how much historical data is being uploaded into the Born system, but the data will still be available, the pre-data, so we could still do analysis with it.
Okay, that's great to know. Well, thanks for answering.
Now, there's some questions online here. I've just got to scroll and find them. Sorry, this is me being slow here. Can we see the screens prior to implementation so that we're... Oh, sorry, it moved on me. The question was, every time somebody puts a new question in, the whole screen moves. Just this one, up or down? Down. This one. Okay, the next question came, will data be accessible to be able to determine turnaround times for prenatal screening data? Will data be accessible to be able to determine turnaround times for prenatal screening data? If the person who put that in could clarify, I'm not exactly sure I know what that question means. So just redo. It'd be great. Next question was a minor issue. Is there a way that these sessions can be changed to another time during the day, earlier AM or later PM would be nice? We can always look at that. We did we asked people in advance, and this was a good time. They are, however, recorded and posted to our website, so you can go to the system there and look. Would we by chance have, sorry, it moved again. Would we by chance have a list of new data elements that will be available from the new database? Would it be possible to share that list? The data dictionary for BORN is available online. It's www.bornontario.ca/data-dictionary. And you can go on there and look at the data dictionary. And if you didn't get that, let me know and I'll repeat it at the end. The other question is, can we see the screens prior to implementation so that we are collecting the required data on our forms? That will be part of the education process that's happening with the regional coordinators as they go along. They'll be sharing that information with you soon. Another question, please clarify near-term pathway on NIDA form, or will this be deleted from the new form? And again, I'm not sure I know what that means. If you could clarify that question, that would be very helpful. I'm just seeing the systems. Is there a plan to have a general release of information for clients being added into the database? Is there a plan to have a general release of information for clients being added into the database? I'm sorry, again, I'm not entirely sure what that means. You can either call into the system if you have a specific question, or you can try and clarify. Okay. Oh, okay. So Barb Chapman, who's our data specialist here, wrote in the near-term pathway is not in the newborn data set. So there's the answer to that question. Am I missing anyone, Britton? Okay. Follow-up question. Is the data dictionary on the website up to date with the new data elements? Yes, it is. And the pick lists are all there. So again, it's www.bornontario.ca/data-dictionary. Are there any other questions? I don't see any online. Feel free to email me. You can either get me through science@bornontario.ca, or you can email me directly. My email address is aspragg@ottawahospital.on.ca.